Welcome back, everyone. I'm Dr. Evidentia, and I'm so glad you're joining us for this evidence-based explainer. Today, we're diving into a really fascinating and frankly kind of unsettling medical mystery. It's a condition where the body's absolutely most critical warning system just goes completely offline during a life or death moment. We're going to unmask the science behind silent myocardial ischemia. We'll look directly at the most recent literature to figure out exactly how this happens, who is really at risk, and how modern medicine is trying to outsmart it. Let's get into it.
But first, just a quick heads up before we dive into the science. My goal here is to help improve your health literacy using reliable evidence. So this explainer is strictly for educational purposes to help you wrap your head around some complex medical research. It's never a substitute for professional medical advice or a personal prescription. Please, for sure, always consult your own physician regarding your personal health.
All right, here's what our clinical round syllabus looks like today. We're going to cover the heart's missing alarm, how cardiac pain works, why ischemia goes silent, identifying high-risk patients, catching a silent condition, and finally, we'll wrap up with the treatment debate.
Okay, Section 1, the heart's missing alarm.
So what exactly are we dealing with when a patient is having serious cardiac stress, but without those hallmark warning signs? We're talking about silent myocardial ischemia, or SMI. Basically, it's an inadequate supply of oxygen-rich blood to the heart muscle. Now, normally, when this happens, your body throws a massive warning signal, angina, which most of us just know as chest pain or pressure. You can think of angina as your body's fire alarm. It's screaming, hey, there's a huge problem down here, get help right now. But with SMI, that alarm is completely silent. The damage is happening, the oxygen deprivation is real, but the patient feels absolutely nothing out of the ordinary.
So what happens when your heart is in serious danger, but the alarm system is essentially disconnected? Well, without that pain to tip you off, the diagnosis gets severely delayed. A person might literally just go about their normal day, completely unaware that their heart muscle is starving for oxygen. And this sneaky progression significantly increases the risk of serious complications, irreversible heart damage, and unfortunately, even mortality. All because medical intervention simply isn't sought in time.
Moving on to Section 2, how cardiac pain works.
To understand how the alarm gets disconnected, we really need to understand how it's wired in the first place. When the heart muscle, the myocardium, isn't getting enough oxygen, you get this biochemical imbalance. The body starts releasing these distress substances, principally a little molecule called adenosine. This adenosine acts like a tripwire. It stimulates afferent sympathetic neurons, which are essentially the sensory nerves that carry distress signals away from the heart, kicking off your internal alert.
And those activated nerves, they don't just hang around the heart. They shoot straight up through a highway, actually a really complex network of nerve fibers called the cardiac plexi. They race straight through the body's communication chain without even stopping to pass the baton to another nerve cell. They're effectively wiring the heart's distress signals directly up toward the central nervous system, speeding right toward the spinal cord.
Now, here is where the perception of pain gets a bit complicated. When these cardiac pain signals reach a very specific area in the spinal cord called lamina I, they converge with sensory nerves coming from totally different parts of your upper body, like your arms, your neck, or even your jaw. Because these internal visceral pathways and your regular somatic sensory pathways merge onto common transmitter cells right there, your brain actually has a really hard time figuring out exactly where the pain is originating. And that's exactly why angina is rarely the sharp, localized pain right over your heart. Instead, it's usually this vague, poorly localized pressure or discomfort spreading all across the upper body.
All right, Section 3, why ischemia goes silent.
Okay, so that's how the complex, highly sensitive alarm system works when it's functioning perfectly. But why does this vital alarm just fail in certain patients, plunging them into silent myocardial ischemia? Well, first off, we have to recognize that this silence happens in very different clinical scenarios. There are actually 3 types of SMI. Type 1 involves patients who have coronary artery disease but absolutely no symptoms whatsoever. Type 2 occurs in patients who already have a history of a prior heart attack, and Type 3, which I find really fascinating, happens in patients who sometimes experience typical chest pain but also have these concurrent, completely silent ischemic episodes mixed in. So as you can see, it affects patients with wildly different cardiac histories.
Structurally, what's actually causing this silence? Well, in a lot of cases of SMI, the pain threshold itself is actually elevated. Autopsy studies of certain high-risk patients have shown real anatomical disruptions in the cardiac sensory nerve fibers. We're talking fragmented sensory fibers in the myocardium, a reduced number of fibers overall, and even abnormal thickening of the nerves.
The brain simply never registers the ischemia because the actual physical wires transmitting the alarm have been damaged. It's literally like having dead batteries in your smoke detector.
Let's look at Section 4, identifying high-risk patients. If we know the nerve fibers can be damaged like this, who does the epidemiological data say is most likely to experience this dangerous sensory neuropathy? Well, consider this completely staggering statistic. 50 to 70%. The literature indicates that 50 to 70% of transient ischemic episodes do not present with anginal chest pain. To put that into perspective, the majority of these daily ischemic events across the broader population are entirely silent. It's a massive, massive clinical blind spot.
So who's really in the crosshairs here? Patients with type 2 diabetes mellitus are at a very heightened risk. Over time, high blood sugar can damage nerve fibers all throughout the body, including the heart, which is a condition called cardiac autonomic neuropathy, or CAN. In fact, evidence from major trials, like the ACCORD study, shows that diabetic patients with CAN have an incidence rate of silent infarctions exceeding 1.5 times that of those without it. We also see high prevalence in patients with chronic kidney disease, and notably, in perioperative patients who are recovering from non-cardiac surgeries, where ischemic damage often happens without the patient ever reporting typical chest pain.
Which naturally brings us to the most practical question of this entire explainer. How on earth do we catch a condition that has literally no symptoms? It's a huge challenge. And hey, by the way, if you're enjoying learning how to navigate these medical mysteries using structured evidence, please make sure to hit that like button, subscribe to the channel, and leave a comment below. It absolutely helps us keep bringing you this clear, science-backed content.
All right, Section 5, catching a silent condition. Now, it's important to point out that European Society of Cardiology guidelines recommend targeted screening specifically for high-risk individuals like those with diabetes or a really strong family history, rather than just screening the general healthy public. Since we obviously can't rely on the patient feeling pain, we have to look directly at the heart's function and blood flow while it's under stress. We might use an exercise treadmill test to look for electrical abnormalities like prolonged ST segment shifts on an EKG while the patient exercises. Or we use advanced imaging like stress echocardiography to physically see if certain walls of the heart stop pumping properly when the heart rate goes up. We can even use cardiac MRI or super advanced nuclear imaging like SPECT and PET scans. These incredible tools use harmless radio tracers to visualize exactly where blood flow is compromised in the heart muscle. So it exposes the ischemia even when the patient thinks they feel perfectly fine.
And finally, Section 6, the treatment debate. Once we use all these cool tools to uncover the silent ischemia, we enter a really fascinating clinical debate, where we have to clearly separate established foundational treatment from areas where there's still some medical uncertainty. On one side, we have optimal medical therapy. This means using anti-ischemic medications, aspirin, and strictly controlling risk factors like blood pressure and cholesterol. This is universally recommended and highly, highly effective. On the other side, though, is invasive revascularization, or percutaneous coronary intervention, often just called PCI. This involves actually placing stents to prop open narrowed arteries. Now, for patients with severe symptoms, stents can be an absolute lifesaver. But for silent, asymptomatic ischemia, the evidence is actually heavily debated. Some observational studies do suggest a survival benefit for stenting, but major randomized data, like a post-hoc analysis of the COURAGE trial, showed that performing PCI on top of optimal medical therapy for SMI didn't really provide any additional survival benefits. So cardiologists have to weigh these options very, very carefully based on a patient's individual anatomical risks.
Let's wrap up our clinical rounds today with a few core takeaways. Silent myocardial ischemia is dangerous precisely because it completely removes the body's natural fire alarm, which is angina. It's remarkably prevalent, especially among patients dealing with diabetes and autonomic neuropathy. And because there aren't any symptoms, we have to rely on advanced functional imaging like stress echoes and nuclear scans just to see the ischemia. And finally, when it comes to actually managing SMI, the absolute cornerstone is optimal medical therapy, with invasive treatments like stents generally reserved for patients with very specific, high-risk anatomical blockages.
You know, the human body is incredibly complex, but by breaking down the data, we can really remove a lot of the fear of the unknown. Think about it. If your heart couldn't warn you it was in trouble, would you know how to listen? If you or someone you love falls into any of the high-risk categories we talked about today, take this knowledge and have a proactive, informed conversation with your healthcare provider. My mission is helping people make informed health decisions through reliable evidence. Thank you so much for learning with me today. Keep asking great questions, and I'll catch you in the next explainer.